Hello friends, today I am going to give a demo of interlocking nailing in fractured shaft femur lower third in a 72 years old female. This patient sustained this injury due to fall on the ground. Usually this fracture occurs due to high velocity trauma in young adults, either due to road traffic accident or fall from height. But in old age, this may happen in a trivial trauma due to fall on the ground. So let us come to the demo of this surgery. This is the X-ray of the same patient having lower third short oblique type of fracture of the shaft femur. As you can see, in the other limb, the patient has been operated, that is interlocking nailing has been done 4 years back for the fracture of the shaft femur. So this time the patient had come to me for the lower third fracture of the shaft femur or other limb. So let us come to the surgery. First of all, I will make an incision just above the greater trochanter, about 2 to 2.5 centimeter diameter, and then after blunt dissection of the tissues, I am introducing a bone out just medial to the greater trochanter in the piriform fossa in AP view. As you can see in the CR picture, and in lateral view, it is at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. As you can see in the CR picture, I am hammering the bone out inside the intramedullary canal so that it can enter in selected exact entry point. And this is the lateral view. You can see that it is at the junction of the anterior 2/3 and posterior 1/3. You can see in the picture and AP view, this is the lateral view, this is the AP view, and this is the lateral view. Again, I have focused to confirm the entry point. And finally, after confirming in the CR picture the correct entry point, I am introducing by a screen movement of the CR, and you can see that this is the AP view. It has gone in correct position, and in lateral view also it has gone in correct position. That is at the point of the anterior 2/3 at the junction of the anterior 2/3 and posterior 1/3 of the greater trochanter. So after confirming it, I am going to introduce still I am introducing the bone out inside the intramedullary canal, and finally a 2.5 millimeter guide wire is being introduced inside the intramedullary canal, just lateral to the bone out, which has been pulled out to make a space in the lateral part of the bone out to introduce the guide wire. And finally, after introducing the guide wire, we removed this bone out, and then after reduction of the fracture with the help of the F tools, my assistant is holding this fracture in proper position, and the guide wire has been introduced in the distal fragment. And after introduction of the guide wire, we are going to ream the medullary canal with the help of 9 millimeter reamer, and it is being reamed with 9 millimeter reamer, hand reamer, and it has crossed the fracture, and my assistant is keeping the fracture in reduced position throughout the nailing process with the help of the F tool. During reaming process also, it is kept in reduced position, otherwise there may be malalignment of the fracture. And I am doing reaming with a 10 millimeter reamer, and still my assistant is keeping the fracture in reduced position, and I am confirming on the CR whether the fracture is in reduced position or not. And this is in reduced position, the slightly distracted, but in reduced position, in AP view, and also in lateral view. This is the oblique view. And after performing in the CR in both view, we did reaming up to the lower end of the femur, and finally we reamed this fracture with the help of power reamer 11 millimeter. Because the patient is old one, so reaming is easy. It is just to measure the size of the intramedullary canal, the diameter of the intramedullary canal, the what size of the nail should be introduced so that it can fit in the intramedullary canal. The fitting nail can be introduced. So this is the purpose of reaming, because the patient is old one, osteoporotic. Throughout the nailing process, reaming process and nailing process, the fracture is kept in reduced position by my assistant, and the fracture has been reamed up to the lower upper end of the patella, as you can see in the CR picture. You can see in the CR picture it is reduced, although there is slightly distracted, but in reduced position. And finally, it has reached up to the lower end of the femur. And now I am measuring the size of the nail with the help of the CR. And after selecting the proper size of the nail, I have mounted a 10 millimeter, a 11 millimeter, 11 millimeter nail on jig, and finally I am hammering the nail inside the intramedullary canal and keeping the fracture in reduced position with the help of my assistant, so that the malalignment can be prevented and finally I have introduced the appropriate size nail up to the upper pole of the patella. It is good position, the fracture is reduced in both view, in the oblique view and lefty view and lateral view. And then I will remove the guide wire before proximal locking, and now I am doing proximal locking after removal of the guide wire. So you must keep in mind that before locking you have to remove the guide wire. And I am doing proximal locking. The proximal hole in the proximal fragment the near cortex is perforated with the help of 2.5 millimeter K wire, and the distant cortex is drilled with 3.2 millimeter drill bit, and finally we select a proper size 5 millimeter screw for proximal locking, and I am still making a hole in the distal fragment, distal cortex, and now I am tightening the screw, the second screw in the proximal fragment. As you can see in the CR picture, the proper size screw has been tightened in proper position, and it is confirmed that it is inside the hole in both AP and lateral view. And now I will do the distal locking by freehand technique. I will make the hole circular after adjusting the CR in lateral position, and I am tightening the screw after drilling with 3.2 millimeter drill bit. As you can see in this picture, and both the screws have been tightened and confirmed in AP and lateral view. The size of the screw is confirmed in the AP view, and whether it is inside the hole or not, it is confirmed in lateral view. The size of the screw is slightly larger than it should be, but it was accepted because the effect of anesthesia was wearing off. So it was accepted, and you can see that both in AP and lateral view, both proximal as well as the distal screw are in place and in proper position. And now I am going to close the wound after forceful wash of the wound, so that now I am closing the wound after forceful wash of the wound. Now the wound has been closed. And my surgery is over. So thank you to my assistant, my anesthetist, and all the supporting staff for successful surgery of this 72 years old female for the fractured sharp femur, which had been operated on the other side elsewhere 4 years back. So this is on the whole a successful and well executed surgery. Thank you.